Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. We know that CBT-I is the gold standard treatment for insomnia. For too many, though, it remains inaccessible either due to cost or the availability of trained professionals. When we look at those with comorbid mental health disorders, insomnia treatment may improve both their sleep and their mental health. However, sleep restriction therapy may not be the most appropriate modality. Dr. Chris Bojrab is a private practice psychiatrist who has embraced sleep care as a vehicle to improving the mental health of his patients. He is the team psychiatrist for the Indiana Pacers and serves as a medical consultant for other professional sports organizations in Indiana. He also has expertise in neurotransmitters and is here to combine both of these interests as he discusses pharmacological treatment of insomnia and some important considerations in those with mental health disorders. Welcome. Thanks for joining us today.
Thanks for having me.
So you told me that you treat a lot of depression and anxiety with CPAP. So are patients receptive to having a sleep study and wearing CPAP? Where I'm going with this is I think maybe you might catch them off guard because you're a psychiatrist and you're not a sleep physician.
Well, that's true. And I do explain to patients up front that I don't have any other nefarious considerations going on in the back of my head. I don't own a sleep lab. I get nothing tangible to benefit by trying to evaluate them or treat them for a sleep disorder. I always tell them that my interest in sleep is just sort of clinically selfish because knowing a little something about sleep makes me a better shrink. As I've gone through training and been in practice for over a quarter of a century, I've just come to realize that it's a really good investment in time with patients and in terms of our continuing education to try to become a little knowledgeable about sleep. It's a good return on the investment of time and energy because sleep really touches every aspect of a person's health or mental health and their functioning. So there's a lot of potential gold to be mined there, I think.
I love that approach, the gold to be mined. So are you in an area with good access to CBT-I?
Unfortunately not. I practice in Carmel, Indiana, which is a suburb of Indianapolis. So we are a large city. We have excellent healthcare resources. But if you were to ask me what our areas of failing are, I would tell you that for a city this size, we have precious little in the way of access to really good CBT-I. There's a handful of providers to whom I refer, but I'm not even sure if there's anybody that does this really exclusively. And I would implore any people going in training out there to think about relocating to Indiana. We would keep you filled immediately.
I should probably put in a plug for Fargo too then. So, I think you probably then do a little bit like I do too, where we talk about CBT-I and we kind of talk about the basic tenets. And one of the central tenets is sleep restriction therapy. But we also know that really we maybe don't want to do this in somebody with bipolar disorder, for example, or other psychiatric conditions. So do you feel like in our patients who have comorbid mental health issues that there's still a role for CBT-I without sleep restriction?
I think so. I think even starting simpler, just with good attention to good sleep hygiene practices is a great way to start with patients. And unfortunately, it frequently becomes a do as I say, not as I do kind of exercise. But I think helping people to understand the importance of sleep, I usually set it up by explaining to patients that, sleep is not what your brain is doing when it just doesn't have anything else to do. It is its own active biologic process that involves a lot of areas of the brain that are just different in their level of activity when we're asleep than when we're awake. But you shouldn't think about just it being akin to plugging in your phone at night and just letting it rest and not do anything else. There's all sorts of things going on. So it's really important to do what we can to sort of set the stage for all of those important neurophysiologic processes to be able to proceed as they're designed to.
So, how do you tie that into, let's say, anxiety or depression?
So it's, I always tell people that it's really sort of a two-way street, that certainly when patients come in suffering with symptoms of a clinically relevant mood or anxiety disorder, it's very common for them to see disturbances in their sleep, whether that's insomnia or hypersomnia or changes in sleep inertia. But I also point out to them that it's a two-way street, because if you take people who don't previously have a history of depression or anxiety and you significantly alter their sleep, you can induce symptoms of depression or anxiety in people just by either restricting their sleep or changing the way they sleep or changing the time that they sleep. So it's important both as a symptom to monitor, and it's also important as a lifestyle management technique.
And are your patients receptive to that then?
To varying degrees. I think in this country, we really sort of have this ethos of being the hardworking Americans, and I don't need much sleep, and I get by just fine with a very small amount of sleep. And I point out to them that in all likelihood, that's not the case. There may be 10% of the population on either extreme of the bell curve that are long sleepers and really do function best and require noticeably more than 8 hours of sleep, and there may be a 10% on the other end of the bell curve that really seem to function pretty well with less than 8 hours of sleep. But the degree to which people assume they function adequately with significantly more or less sleep than normal is much higher than those that actually can do it. So we're not very good judges of our own sleep quality or quantity.
So, how do you tie that in then with kind of your love of neurotransmitters?
So, I point out to them that, again, sleep is this incredibly complex process with different stages and different things that occur neurochemically and hormonally at different stages of sleep. And that if we are just not getting an adequate amount of sleep, we're sort of shortchanging all of those symptoms. But if we're suffering from sleep disorders such as sleep apnea, or if people have broken sleep, they have intermittent wakenings throughout the night, that can sometimes be disproportionately disruptive to the more important, deeper stages of sleep. So it's not like every minute of sleep throughout the course of your evening is equally valuable. The greater amount of time that we spend in the lighter stages of sleep and up in stage 2 sleep, may not be as meaningful to at least some of the mental restoration, learning, memory consolidation, hormonal work that's going on, as are the deeper stages of sleep, slow wave sleep as we refer to it.
So when you see a patient de novo and you kind of get this feeling that, oh, yep, I'm sensing they have anxiety or depression or bipolar or whatever, how do you then figure out what to treat first and comorbid insomnia? So do you tackle the insomnia first? Do you tackle the mood disorder first?
Like always, I think it varies from patient to patient based on sort of what the preponderance of their symptomatology is. So we do sort of assault patients with sleep questions. So on our questionnaire, I typically ask patients, what time do you go to bed? How long does it take you to fall asleep? Once you've fallen asleep, are you asleep through the night, or do you wake up? If you wake up in the middle of the night, how often, for how long, and how long does it take you to get back to sleep? Why are you waking up in the middle of the night? Are you waking up with pain? Are you waking up anxious? Or are you just waking up? Are you waking up because of a need to use the restroom? Or are you just using the restroom because you happen to be awake? What time do you typically wake up? How often do you wake up with your alarm versus naturally? How much does your sleep and wake time change between the weekday and weekend? Are you taking any prescription medications to help you sleep or relax or to fall asleep? Are you taking any prescription medicines to help you wake up? What's your use of caffeine or other stimulants like? Are you taking any non-prescribed medications or supplements to help with these things? I do some general screening questions to look at to do a little bit of zebra hunting, asking them about things such as hypnagogic or hypnopompic hallucinations, frequency of sleep paralysis. So since it's near and dear to my heart, I sort of do probably go a little overboard with the sleep questions.
I was actually thinking the opposite. I was like, wow, that sounds fantastic. And I feel like by you directly asking them on your intake questionnaire, you've kind of positioned it as something that you want to talk about. And I think patients would infer then that sleep is an important component of their mental health.
Absolutely. I mean, I do think that's one of the side benefits is that they know it's something that's important to me. And after being under my care for a while, they sort of know that I'm always going to be asking them about their sleep each and every time that I see them for follow-up, especially for my bipolar patients. I always explain to them that listen, I think I do an awfully good job of keeping my bipolar patients out of the hospital, and my best strategy for doing that is teaching you to pay attention to your sleep. It's frequently the canary in the coal mine. So I tell them if you have more than a couple of nights sleep disturbance where your sleep seems significantly different than other nights, don't sit on that for a week or two. I want to know before the third night hits. And I'm fairly generous with hypnotics to those patients, and I use them fairly aggressively if their sleep starts to go awry, because I tell them that frequently sleep disturbances is one of the first warning signs. It's the harbinger of a upcoming either depressive or manic phase. And I also tell them that it's also one of the best ways to drive yourself into depression or mania is if you significantly alter your sleep. So you got to make this a priority, not only because it's good for your health and it's good for your sleep health, but because of this mood disorder that you have. It's one of the most tangible things that you have control over to try to keep yourself out of trouble or to give us an early warning sign.
I love that you liken it to that you teach them that it's an early warning sign. So when you talk about using hypnotics, do you have sort of a go-to?
It sort of depends, and I sometimes am worried that maybe I'm a little too maybe I have too low of a threshold for using medicines. I think throughout our training we are really sort of we have it beaten into us about good doctors don't prescribe sleep medicines. Good doctors don't prescribe anxiety medicines. The truth is all of these things have a place at the table, or they just wouldn't be on the market at all. So it's really about what's the appropriate level of use or frequency of use. One of the things that's been concerning to me over the past year or two is there's a big pushback from the insurance industry where they are just unilaterally cutting down, changing prescriptions that we have written for patients, sometimes just arbitrarily deciding that they're only going to fill 50% of a patient's prescription or a third of a patient's prescription, and not even notify the prescriber about this. So we don't hear about it until the patients angrily come in and say, well, why did you cut my sleep medicine in half? I get the concern. These are medicines that are problematic. A lot of our more traditional sleep medicines especially, well, some of them aren't really that great for sleep health, actually. Some of them are good ways to knock yourself out, but they're not necessarily good for preservation of sleep architecture. But, but I do think that more of our modern medications, they really have been studied, oftentimes in longer term use, so they can be appropriate. It's not always the case that we can, or maybe even should, always get patients off of these medicines. For some people, they are going to be indefinite treatments, not because they're without potential risk, but it's about weighing the potential risk of a bad night's sleep repetitively and chronically over time versus whatever inherent degree of risk there does exist from taking these medicines in the long term. So it's not a all or nothing proposition. So I just try to have that conversation with patients about what the risks are and how those risks fall out for them individually, which has a lot to do with their other medical conditions, which has a lot to do with their age. So I do think that sometimes we, through our training, we're just really that attention to the importance of sleep is given pretty short shrift. I know in my training, we got maybe a 1 or 2 hour lecture on sleep. And I'm hoping it's better now. But
But
I don't
you've
know.
hit on something important, right? Like that's a conversation I have too with patients that are sort of on hypnotics long term, that it's assessment of risk and benefit, right? There's risk of medication, but there's also risk of not sleeping, not sleeping well. And sometimes it is, I mean, you're right. We have this messaging all the time that it's CBT-I, but there was some data demonstrating that by the time somebody sees a sleep physician, and this may also apply to coming to see you in practice, that they're past the CBT-I and the sleep hygiene. They want medications. And so then it's almost the opposite, where we start the hypnotic, depending on, right? As we do CBT-I and as we kind of get more of this, teaching them how to sleep better, and then maybe wean it off.
Absolutely. It's and of course people want the easy fix. So it's sometimes it takes more encouragement to get them into either into a CBT-I program or just trying to follow the tenets of good sleep hygiene, and pointing out to them the impact sometime of their daily schedule on how they sleep. Not all sleep is created equal. I have a lot of patients, probably 20% of my practice are healthcare providers. And among this group are a lot of people that work non-traditional hours or non-traditional shifts. And that is really hard on people. People don't realize the toll that changing shifts or that doing shift work takes on there's a reason they pay you a shift differential, and they're not paying you enough, because we know that under the best of circumstances, even among healthcare providers who are on average healthier than the general population, we know that if you are in a specialty where you are working night shifts or where you are swinging shifts, that on average your life expectancy is reduced by about 5 years, with the preponderance of the excess mortality coming from cardiovascular deaths and cancer. So even if you're doing everything you can to pay good attention and try to manage your sleep environment during the day to the best of your ability, wearing eye shades, blackout blinds, cool, comfortable room that's quiet or has white noise in the background, you're doing all the right stuff, it's still not the same quality of sleep that you normally would get if you were sleeping more normal human hours and getting some of those, neurophysiologic boosts to our sleep that most of us enjoy. So it's important that people realize the impact that these changes in sleep can have, even if they feel like they're getting the same number of hours that they used to.
Mm-hmm. No, you're exactly right. So I heard you say earlier, talking about, looking at why people aren't sleeping well, and you mentioned pain. So if you have a patient who has pain and insomnia, how do you approach that? Do you have a certain medication that you choose?
I think that it certainly increases the stock value of those medicines that may help to be a twofer, right? Medicines that can help with pain and sleep, or with pain and anxiety, or at least trying to pay attention to not making the situation worse. The difficulty in psychiatry is that most of our antidepressant medicines are actually not great for sleep. Even those medicines that we consider to be calming or sedating are really not great for sleep architecture. Our antidepressants, for example, the vast majority of our antidepressants are not good for sleep. They're disruptive to sleep architecture. Medicines that impact the serotonin syndrome, or the serotonin system especially, can cause decreases in REM sleep, decreases in slow wave sleep. And even those antidepressants that are more sedating, that might buy you longer time in bed. That might make you fall asleep a little bit easier, but you actually have relatively disrupted sleep compared to somebody not taking an antidepressant. Now, the saving grace there is the fact that typically depression and oftentimes anxiety is likely more disruptive to sleep than are the medicines. So taking the medicines can still be a net improvement for the patient. But if we have patients for whom sleep is really a primary issue, sometimes we'll try to focus on those antidepressants that may be kinder to sleep. and some of them that we use actually as sleep medicines. Trazodone, for example, is an old sweetheart medicine that was not developed to be a hypnotic. It was developed to be an antidepressant. It just turned out to be too sedating, to be too useful as an antidepressant, because you probably have to take north of 400 milligrams to get a really good antidepressant effect.
Is it really that high? I didn't know that.
Yeah. I mean, listen, from the get-go, you may get some benefit, but if you're trying to primarily use trazodone as an antidepressant, you're probably looking at 300, 400 milligrams or higher. And as I always joke with patients, it's like, then I come up to you and shake you. I'm like, hey, wake up. Are you feeling less depressed? But trazodone, also nifazodone, and mirtazapine are sort of the triumvirate of antidepressants that may be kinder or even beneficial for sleep. And one of the things that all three of those medications have in common is that those are all serotonin type 2, 5-HT2 antagonists. So we know that when you block 5-HT2 receptors, one of the things that seems to be associated with that is some improvement in the amount of time that people spend in slow wave sleep. So oftentimes with those medicines, not only are they sedating so they can help people fall asleep, there's some evidence to suggest that they may be somewhat protective or enhancing of slow wave sleep. And I think oftentimes patients that are taking medicines that have that pharmacology, which incidentally almost all of our atypical antipsychotic medications have as well, that 5-HT2 blocking effect. Sometimes people will report sleeping better, sleeping more soundly, or sleeping more efficiently, sometimes finding that they get by with fewer hours of sleep than they had before, but feeling better rested. So it sometimes is a good trade-off because your sleep efficiency may increase.
So that's interesting. Does it do anything to REM?
So antidepressant medicines on average suppress REM. In fact, that used to be one of the ways we would screen potential molecules to see if they might be antidepressants. Is in animal models, you would say, is it screwing up their REM sleep? Oh, good, this might be an antidepressant. And if you selectively deprive people of REM, that actually can help acutely treat their depressive symptoms. Now, it's not sustainable in the long run because people will rebound into more REM as soon as you stop that, and then the depression can get bad again. But yeah, so that really, I think the claim to fame of some of our newer hypnotics is that they're relatively hands-off when it comes to REM sleep. So unlike most of our antidepressants and medicines that we have historically used for sleep, like benzodiazepines. So benzodiazepines are also medications that will have a tendency to suppress slow-wave sleep and suppress REM sleep. And really the newer medications that are GABAergic but are not quite benzodiazepines, so things like zolpidem and zaloplan and azopiclone, these are not just newer, more expensive benzos. They're a little bit different, where they bind on the receptor is a little bit different, and they seem less disruptive to sleep architecture. So they in general are better at preserving slow wave sleep and REM sleep compared to our just straight old benzodiazepines.
So let's take a short break, and when we come back, we'll talk more about medications to treat insomnia in those with a mental health disorder. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Your membership in the AASM demonstrates your commitment to advancing sleep care and enhancing sleep health to improve lives. Stay connected to the thousands of colleagues that share your passion for healthy sleep. Renew your membership today at aasm.org.
Welcome back to Talking Sleep. We're talking with Dr. Chris Bojrab about pharmaceutical treatment of insomnia in those with comorbid mental health disorders. So, when I think about REM suppression, I guess my mind goes to the SSRIs and the benzos. And I guess I didn't realize that trazodone also would suppress REM.
Well, I'm not sure that trazodone does. Trazodone is not quite, it's not an SSRI. It's not quite a tricyclic. It's sort of an atypical antidepressant. So I'm not aware that trazodone causes the same type of of disruption. Like I said, the 5-HT2 mediated effect, I think, has been more often talked about in the setting of what it does to slow wave sleep. But I guess and I don't know this for sure, but I guess I've always sort of considered those three medicines, the trazodone, the nifazodone, and the mirtazapine, as being meds that seem less disruptive to sleep. That's interestingly, that's one of the reasons that SSRIs have as a fairly common side effect vivid dreaming, because although they suppress REM sleep, you would think, well, why in the world does it cause more vivid dreams? Well, overall, it suppresses REM sleep, but it also tends to phase shift it later. So even though you're having less REM sleep in general, you have a greater REM density closer to the time that you waken. And that's really what determines how vividly you remember your dreams. Almost everybody dreams. Many people don't remember their dreams, either because they're having less REM close to the time that they wake up, or they're just having some less degree of REM than others do. But antidepressants tend to cause people to squish their REM later into the evening, more likely to be closer to a REM period when they awaken, and that's why people will sometimes have such vivid dreams. Not necessarily bad dreams, but just very sort of vivid, clear dreams.
I have never used nifazodone.
It's not a very commonly used medicine. It was sold under the name of Surzone for a number of years. There was some concern about hepatic toxicity, and since it was never a very popular medicine, I think the manufacturer just sort of stopped making it.
Okay.
Yeah, it's continued as a generic, and honestly, the degree of hepatic impairment with it is not huge. It's been a while since I looked at it, and I still will generally, make sure that either somebody's getting labs done. Maybe I'll check, if we're starting them on Surzone, nifazodone, perhaps I'll check a liver function at baseline, and 6 months later or 3 months later. But I don't know if I've ever seen a patient where I've observed what appeared to be an effect there. But it's never been a very commonly used medicine. But I tell you, it seems like there's this cadre of patients where that's really the only thing that's worked for them, because about a year or two ago, you could not find nifazodone. I don't know if there's just one manufacturer or if there were a couple, but there was none to be had. And let me tell you, these were some unhappy patients because, if we had ended up on nifazodone, it was usually because we had tried all the more routine things, and this was the one thing that seemed to have worked for them. And they were pretty desperate when that was in such short supply for such a long time. As that sort of came back to the market and people were able to get back on it, they were quite thankful. But yeah, it's never been a hugely popular medicine.
Huh. So you sort of touched on insurance earlier. When you choose a medication, do you kind of try to guide patients based on side effect profile, or is insurance a bigger player now for you?
Certainly, insurance is a big player. I mean, most of the branded sleep medicines do have copay reduction plans that can make the medicines more accessible to at least those patients with insurance. Here in Indiana, we have the luxury of having, I think we were one of 7 states in the country where we have essentially an unlimited Medicaid formulary, so our Medicaid patients can have access to virtually anything.
No way.
Yeah, it's far better to have Medicaid than it is to have the best commercial insurance in Indiana when it comes to medication coverage. But of course, the problem we run into is with our Medicare patients, because of course, the government prohibits patients covered or eligible for Medicare, by and large, from using those copay reduction programs. So it creates a problem for access to the newer medicines for those patients. But, I tend to, my approach in general is trying to establish what the pattern of insomnia is. Are people having trouble falling asleep? Are they having trouble staying asleep? Or are they having both? Or are they having problems waking up too early and not being able to get back to sleep? But the majority of people with insomnia seem to have more difficulty with sleep maintenance than with sleep onset. I mean, certainly people can have both, but I would say that's the bigger problem I see in my practice, is people being able to sort of maintain their sleep throughout the course of the night. And I think that there are relatively fewer medicines on the market that have got good data when it comes to sleep maintenance as opposed to sleep onset. And that's one of the reasons that I oftentimes wind up doing combinations of different classes of hypnotics, much the same way that we use different classes of antihypertensive medicines or different classes of depression and anxiety medicine. So I think that's something that gets me the unwanted attention from pharmacies or from insurance companies sometimes. It's like, why do you have this person on two different medicines for sleep? And it's like, well, because we've tried one then the other, and neither seems to address both the onset and the maintenance issue, and sometimes overall the patient's tolerability, even though it's a little messier because you're using two medicines instead of one. Sometimes that's a reasonable polypharmacy trade-off if you can get by with smaller doses of the two. The classic example is probably trazodone. So trazodone is great because people love it because it's not habit forming and it's pretty safe, even though it probably has a little bit more cardiac activity than most people realize. But nothing is completely innocuous. But with trazodone, sometimes the difficulty is finding a dose that both gets you to sleep in a reasonable amount of time, keeps you asleep throughout the course of the night, and doesn't leave you feeling hungover in the morning. If you can find that sweet spot, then great. It's a great monotherapy. But oftentimes I'll do a quicker onset medicine like a Zaloplan that's very short acting but good at helping people fall asleep, and then also pair that up with trazodone to help sort of with the sleep maintenance, and sometimes get by with overall less side effect than if I was either using a more traditional GABAergic agent or even if I was using one of the other non-GABAergic agents. So I think the idea of combining hypnotic medicines that have different mechanisms of action, whether that's a GABAergic medicine, whether that's a more generally sedating medicine, whether that's something that's impacting 5-HT2 or the newer classes of medicines like the dual orexin antagonist medicines. I think there's some rationale, even though we don't have FDA approvals for combination use. I think you can make a pretty compelling pharmacology argument why that's a potentially reasonable thing to do.
What about if they have similar mechanisms of action? So I'm thinking about like zolpidem sleep onset and then PRN, Zaloplan, middle of the night.
I certainly wouldn't say that I never do that. I think those are always the patient that you sort of want to say, hey, you can't go see anybody else because they'll think I'm a maniac. Right. But no, I do love me some Zaloplan. I mean, I think it never got off the ground as a primary medicine because it's so short acting, but that's part of its charm, really. So it's the medicine that I feel a little more comfortable telling patients that, hey, you can take this in the middle of the night if you need to. And I think there was even some data from back in the day where they said if you looked at like psychomotor vigilance tests or balance testing and so forth, that after about 4 hours, most people look like they haven't taken anything. So if I'm going to use something, PRN in the middle of the night, or even in a more sustained way in the middle of the night, that's been a sweetheart medicine of mine.
Yeah, I kind of like it too, just for the PRN middle of the night awakenings. Yeah. What about like Silenor?
So Silenor is an interesting medicine. It's like the world's most expensive doxepin.
It's crazy, isn't it?
Yeah. And so people really say, how different is 3 or 6 milligrams versus 10. Now,
versus 10, exactly, yes.
Yeah, so doxepin is available in 10 milligrams. It's the smallest commercially available pill, and of course it's a capsule, not a tablet, so you can't split it. And then the Silenor is available as a 3 milligram and 6 milligram dose. Now, what the company claimed is that it really was different than just giving people a bigger dose of doxepin. Doxepin is pretty profoundly sedating. It may be one of the strongest antihistamines on the face of the planet. I think it's something like 700 times the receptor affinity for histamine that like Benadryl has. It's something crazy like that.
Oh, wow.
Yeah, it's actually I tell you, if you want to look like a genius on your internal medicine rotation, and your team was treating a patient with mastocytosis X, and you come up with the idea of using doxepin, you look like a hero. So,
I was wondering where you're going with that one.
yeah, and you can also like treat their peptic ulcer disease and their allergies with it too. So
Wow.
but the whole play behind Silenor was that you were using a dose of doxepin that really kept you below the dose where it became more noticeably sedating, and it was felt to perhaps be more of a medication that would help actually trigger part of the sleep-wake apparatus in the brain. So, as we look at that complex system between the suprachiasmatic nucleus, the timekeeper for the brain, and then the ventrolateral preoptic area, sort of the sleep center, and versus the tuberomammillary nucleus, the wake center of the brain, and how those things balance between each other. I think that the belief was that the very low dose of Silenor was one of the things that could help sort of initiate that signaling process, to allow people to fall more naturally to sleep by trying to reinforce some of the natural sleep mechanisms there in the brain, rather than just coming in with a wet blanket of something that's more grossly uniformly sedating because of the stronger antihistamine effect.
Yeah, I can't remember the last time I ever had Silenor approved and without just doing 10 of doxepin.
Yeah.
Yeah. What about Ramelteon? Do you use that one?
I do. That's sort of an interesting medication. So, Ramelteon, basically taking advantage of the melatonin system. So, we've got a medication that has sort of differential affinity for the M1 and M2 receptors. Melatonin is of course important in our sleep regulation. It's when people are using it, people say, well, what do you think about melatonin as a sleep aid? And I'm like, I don't have a huge problem with people taking melatonin. If it works for them, that's fine. Nothing trumps reality, right?
Right.
My impression, looking at the data, I think the biggest studies ever done on melatonin in terms of helping with sleep onset is that it shortened, time to persistent sleep by a minute or two. I think it probably is a more effective chronotropic agent. So if people are moving or if they're switching time zones, it may help sort of reset your circadian clock a little bit more. But if it's working for people, I don't have a problem. I do point out that we're a little more cavalier with it here than other parts of the world are. It is, I think it's the only hormone that you can buy over the counter. Other countries, you have to have a prescription for it. So it's not necessarily to be trifled with, although our experience with it has been that it's been pretty safe. So the whole story behind Rosarum is they came up with a medicine that just had better, receptor affinity. And instead of having a half-life of about 25 or 30 minutes like melatonin does, it has a half-life of 5 or 6 hours. So it's not just like a pharmaceutical grade melatonin. It sort of is. It out melatonins melatonin. And one of the problems was though is that everybody had gotten so used to taking medications that made them feel more noticeably sedated that if patients had been on benzodiazepines or GABAergic acting sleep medicines, and you would try to put them on Ramelteon, it was sort of the same thing that happened with Silenor. People said, well, it doesn't work. Well, why? Well, it doesn't knock me out. It doesn't feel that way. Now, if you look at their clinical trial data doesn't look that different than the GABAergic sleep medicine. So a lot of it was perceptual. A lot of it was like, if you asked people when they felt like they started to sleep better with Ramelteon, a lot of people would say, well, it was probably a couple of weeks or so before it really felt like it was kicking in. But if you looked at the polysomnogram data, it was a fairly quick effect. And again, I think it gets back to that idea that we are not very good observers of our own sleep quantity or quality.
So what about the DORAs?
The DORAs are interesting. I love this part of the pharmacology. So the story, as I always heard it, was that back in the day, people were interested in studying narcolepsy. They finally identified an animal model. They had these goats, and they had some pit bulls that seemed to be a promising model for this. So they said, okay, we're going to study this. We're going to figure out narcolepsy. And then ultimately they found out that animal narcolepsy is probably different than human narcolepsy. A lot of animal narcolepsy is a single gene defect, and that's not the case in humans. So then you had all these frustrated narcolepsy researchers that were trying to figure out what they were going to do now that they weren't going to make millions of dollars or win a Nobel Prize for this. And they said, well, what else lives in that part of the brain? It's like, well, wait a minute, appetite regulation. We'll switch over and we'll research diet drugs, and we'll make $1 billion and we'll get 2 Nobel Prizes. So all these folks that were looking at the orexin system for sleep and they didn't call it orexin back then, but they started looking at this molecule as a medicine for weight loss. And so they engineered a mouse and they knocked out its orexin pathways. And they said, well, here's our model. We'll knock this out. Animals will lose their sense of satiety. They'll eat a lot more. They'll gain weight. We'll come up with a medicine that does the opposite, and we'll be billionaires. And they made these knockout mice, and they knocked out their orexin pathways. And they ate a little bit more, but when they were watching them, they noticed that they were scurrying around at night with their little night vision camera since they're nocturnal, and they would get excited when they would find some food, and they would just fall over.
Oh, no.
And they're like, it's just like those goats and those dogs. And they're like, maybe this is what's going on with narcolepsy. So by this time, they had developed a way to stain for orexin, which actually goes by 2 names. Orexin, from the Greek, orexis, appetite or hunger, and hypocretin, because structurally it bears a lot of homology to the molecule secretin. So they had developed a way to stain for this. And if you stain sort of the hypothalamus of most animals or people, the brain is sort of rotten with these orexin-containing neurons. There's a lot of them there. But if you went to cadaveric brain specimens of animals who had narcolepsy or people who had narcolepsy, what you saw were a lot of loss of orexin-containing neurons and a lot of what looked like post-inflammatory changes. So now one of the theories of narcolepsy is that it may ultimately be sort of an autoimmune condition or an inflammatory condition, in where something attacks the orexin-containing neurons, and orexin turns out to be a molecule that's important for managing sleep and wakefulness. It helps to lock us into a state of wakefulness, and it also can help solidify sleep, which is one of the reasons that patients with narcolepsy who appear to have impairments in this system not only have trouble staying awake during the day and they fall asleep all the time, but they have terrible disrupted nighttime sleep. If you look at the hypnogram of a narcolepsy patient, a lot of my colleagues may not, the sleep specialists I'm sure know this, but a lot of psychiatrists or primary care may not notice this or know this, but narcoleptics have horrible nighttime sleep. It's very disjointed, very disrupted, because it's not just a condition where they fall asleep all the time, it's where they can't really effectively lock into a state of sleep or wakefulness.
Mm-hmm. Yeah, their REM and wake kind of get jumbled up, and yeah. So then, which patients do you think are appropriate for DORAs?
You know, I think they're potentially a pretty broadly effective class of medicine. I really like them. If you just look at the mechanism of action, you could argue that it's the most elegant approach, right? Because it gets us closest to the central control switch for sleep and wake. I mean, we started out, we started out thousands of years ago, right? We figured out how to ferment grains and fruit, and we made alcohol. And alcohol is not a bad hypnotic. It just has crappy kinetics, right? So you metabolize it through like aldehyde and paraldehyde, and those things are fairly toxic and also specifically disruptive to sleep. So the idea of a nightcap is terrible. It will make you fall asleep faster, but you tend to jumble up your sleep and have more frequent awakenings and disrupt sleep architecture. And then we came up with barbiturates, which were great sleep drugs if they didn't kill you, if you didn't suppress your respirations and die. We had benzodiazepines, which people are still very scared of, with somewhat good reason, but far safer than the barbiturates were. Then we had the next iteration of the non-benzo GABA acting meds. So we kept getting better along the way, but essentially a lot of the early interventions were essentially how can I just sort of globally make you tired? I'm just
Right.
going to throw a wet blanket on the brain. So I think the attraction of the DORAs is it really is a little bit more of an elegant solution theoretically, right? You're getting there, you're trying to impact what allows sort of the natural, the inherent mechanisms in the brain that control that balance between sleep and wake. They're not always as out of the box effective, but it is a class that I like. I think unfortunately what happened with the first one that we had on the market was sort of a crime. Merck had the initial product Belsomra, and this was really interesting. This medicine launched at a time that in my opinion at least, the FDA was on a bit of a witch hunt against sleep medicines, and they had very little interest in approving new sleep medicines. And if I recall from the original studies, when they were studying Belsomra, they studied it up to 80 milligrams
80,
in their trials, and
Yeah.
they had safety data on it up to 240 milligrams. And I think the doses that they started with were like around 10 or something. And then so the FDA has their meeting with them and said, okay, you've got great data at 80. You've got safety data up to 240. Tell you what, your top dose is going to be 20, and you have to make a 5 milligram pill too. It's like, well, we didn't study that. I know, but we just wanted a lighter dose.
Yeah.
So I think Belsomra really got hamstrung. I think Belsomra works great if you give 4 times the top FDA approved dose, like they did in the studies. But unfortunately, you can't get it approved that way. The two newer DORAs that came out, the Qvivic and Dayvigo, these are medications that are sort of dosed probably more appropriately, and so I think that they're sometimes a little bit more realistic to use. But again, just because I think it's a more elegant solution and it sounds like the chemistry piece should be more compelling, it doesn't always mean that they're the best medicines, right? And so there's room at the table for all of these things because none of these things work with anything close to 100% effectiveness.
Well, and I love that too, right? Because it isn't just one algorithm and one size fits all. And sometimes you do have to, play around a little bit or have conversations with patients about side effects and mechanism of action. But I feel like you probably have had more luck than getting patients on these medications because you don't have the same hurdles like for Medicaid patients, for example.
Right. I mean, certainly that's been helpful. And the newer medicines, they do have pretty good prescription copay reduction plans. So that does certainly help with the accessibility. But you're right, because otherwise, if you're paying out of pocket, these things are several $100s a month, which just can make them, not accessible. And unfortunately, a lot of the safety concerns, I think we sort of blanket those warnings with things. And I'm not sure that all classes of sleep medicines really have the same level of risk. I mean, from one standpoint, anything that's sedating, anything that clouds sensorium can potentially be a risk for falls. But not all fall risk is equal, right? I mean, if you look at benzodiazepines or even our non-GABAergic or our non-benzodiazepine GABAergic medicines, those things still carry risk, right? If you're over the age of 65 and if you're on a benzodiazepine and maybe if you're on some of the non-benzodiazepine GABA acting agents, your risk of falling is 4.5-fold higher than somebody who's not taking one of those medicines. And falls are a big deal. I always tell my patients, listen, if you turn 65 and the bad luck fairy visits you and says, hey, happy birthday, sorry to be the bearer of bad news, but I got to do something bad to you today. But because it's your birthday, I'm going to let you pick. You can either have a heart attack or a hip fracture, and because it's your birthday, I'm going to let you pick. Well, pick the heart attack. You'll be more likely to be alive in 5 years compared to having a hip fracture at 65. So I'm, even though I use a lot of sleep medicines and I have a lower threshold, I think, than a lot of my colleagues might, with my older patients, we do have this conversation and we try to cut that back because I'm like, this is a substantive risk. And even though other things can also be sedating, with benzodiazepines and maybe with a non-benzo GABAergic agents, they also appear to have an impact on vestibular function that goes beyond just the general sedative effect. And that may be one of the things that puts them in a somewhat higher risk category. and then presumably things that maybe work differently through a different mechanism, they still have the same kind of warnings on them. But my personal belief is that you could make an argument as to why they may be less of a fall risk than things that have multiple reasons to be a fall risk.
So then do you actively try to wean their sleep aids? I mean, how do you decide? Is it more based on their mental health?
I think this is sort of the great lie we all tell ourselves, like I'm going to put this person on Xanax at first, and then as soon as their anxiety is under better control with their antidepressant, they'll magically come off of their benzodiazepine. And I think we try it. I think it's harder in practice. I think it's harder in practice than it is in theory. So the conversation I have with patients when I'm starting them on a sleep medicine is the same as when I'm starting them on an anxiety medicine. I'm like, listen, we're going to give you something that has a high hit rate that has a really good chance of being helpful here for your sleep or for your anxiety. But these medicines work so well that it's going to be somewhat difficult for you to come off of these things because these medicines also can have some degree of withdrawal effect. So even if we're at the point where your sleep is improved, when we go to start cutting this back, you're not going to sleep quite as well. Now, we will do this slowly. We'll do it gingerly, so it shouldn't be overwhelming. But people get really torqued up about their sleep. And so I tell people, you have to approach this from the standpoint of anytime I'm going to make a change and I'm coming off of a medicine that's been helpful to sleep, even those that have less of a risk of withdrawal, you're still going to notice a difference. So don't approach this from the standpoint of, oh, I'm not sleeping quite as well. It took me a little bit longer to fall asleep. I must still need the medicine. I can't come off of it. You have to approach it from the standpoint of, this is my comeuppance. This is the cost of doing business. So I'm going to come down on this medicine, and I just know going into it that I'm going to have a few weeks where maybe it takes me a little longer to sleep, or maybe I wake up a little bit more in the middle of the night, or maybe I'm doing that just because I'm anxious because I know I'm making this change. But press on through that. Now, if you get in a pinch, if things are horrible, if it's been weeks and weeks and these things are still happening, we can go back on it. But just anticipate that there is going to be some difference coming off. But that's hard for people because they get very psychologically protective of their sleep.
Yeah, we talk a lot about the psychological impact of sleep aids, and to understand that that's playing a role. And that doesn't mean that you're never going to sleep again without your zolpidem or what have you. But just understand that this is the process. So yeah, I love the way you reframe that. So any final thoughts?
No, just other than I would extend my plea to my colleagues about paying attention to sleep, learning a little something about sleep is extraordinarily a good investment to make with your clinical time, because it really gives you the ability to impact patients across a wide variety of symptoms. And I think at the start you had mentioned that something about a comment that I had made in an earlier conversation we had about treating a lot of anxiety and depression with CPAP. And I think what I actually said was I treat a lot of Alzheimer's and ADHD with CPAP because patients with sleep apnea, just like patients with most sleep disorders, they have a lot of cognitive dysfunction. And even on testing, it can sort of look like ADHD or it can look like Alzheimer's. So I always tell patients, listen, we want to pay particular attention to your sleep because that's a much more likely explanation rather than an early onset Alzheimer's or an ADHD that's just popping up, because it doesn't do that as an adult. And if it's sleep apnea, that's a fairly easy thing to look at these days with home sleep studies. So if you're primarily interested in sleep apnea, I don't know. I don't know if I should say this or not to a group mainly of sleep specialists. Maybe they feel differently, but from my read of the data, home sleep studies look about as effective as an in-lab study for diagnosing apnea. Now they're pretty limited to that, but I do think that that's a useful test, and given how expensive sleep studies can still be out of pocket for folks, even those folks who have pretty good insurance. If we're pretty clear that we're just looking at sleep apnea, I'm very willing to have people do home sleep studies. Now, I do have a very low threshold for sending them to a sleep lab because I think there's a lot of other things that you might potentially miss there that a home study is just never going to pick up on. But I do think it's a pretty darn reasonable screening tool. And I think just in terms of a cost benefit or a just resource allocation benefit, I think those are pretty reasonable things to do, and sometimes keep people from launching down other paths into workups for other kind of disease states, or it just can make the other things easier to treat. So if they've got refractory hypertension, if their depression is really difficult to treat, make sure you're paying attention to what's going on with their sleep. I remember 20 some years ago reading this study of they looked at a group of patients who had been identified as having treatment-resistant depression, and they didn't really ask them any questions. They just did sleep studies on them all. And I think something like 25% of them had sleep apnea.
Wow.
So yeah, if you have somebody who has recalcitrant hypertension, recalcitrant depression, take another look for sleep apnea.
Well, I can say on behalf of our sleep community, we absolutely would welcome anybody to come join us. We're very nice and easy to get along with. And yes, we love this idea of sort of cross-pollination. So for you and your psychiatry colleagues, we absolutely would welcome that collaboration.
Absolutely.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.